Okay, we're almost to the end, and our final speaker, this is a dubious task, but although we've had pretty good retention today, everybody pretty much has stuck around, which is very nice. You're to be congratulated for that. Is Elizabeth Cedars, and she's one of the newest members of the NCMA team. She's a ear, nose, and throat physician who joined our Dr. Zekowi and company and Homich and Wong, and we were very happy to have her come and join our group. She's trained, received her MD degree from Columbia, her BS from Columbia, and then went to UCSF where she stayed and did her residency in ENT. So I present to you Elizabeth Cedars.
Great. Just to echo that, thank you very much for sticking around. I appreciate your attention in advance. Okay. So I know I was introduced. I'm Elizabeth Cedars. I'm a general otolaryngologist, newest addition to the Santa Rosa Head and Neck Surgical Group. And I'll be speaking to you today about hearing loss. I should have gotten some help from Dr. Paulson, I think, with the title of my talk, but bear with me. Okay, so hearing loss is an extremely common disorder. Oh, I apologize. Thank you. Perfect. That was not intentional, but okay. Hearing loss is an extremely common disorder. In fact, a comprehensive U.S. health survey from within the last 10 years showed that it's the third most common chronic condition, twice as common as diabetes or cancer. It's also increasingly common as we age. So it's estimated that 50% of people in their 60s, but as many as 80% of people over the age of 85 suffer from some degree of hearing loss. And though the majority of hearing loss does occur in older adults, we know that hearing loss can be present in children too, and this can have lifelong consequences. The incidence of permanent hearing loss in newborns is between 1 and 3 per thousand, but this rises to between 9 and 10 per thousand by the time kids reach school age. And there have been population studies that show that the overall incidence of at least mild hearing loss in one or both ears for all children and adolescents is over 3%. So the causes of hearing loss are many. In children, the vast majority are due to conductive etiologies. But when sensory neural losses are present, 50% we actually don't know the cause of. Roughly 23% is found to be genetic in origin, and 20% is acquired, often postnatally. In adults, causes include normal age-related changes, which often do have a genetic component, exposure to noise or other environmental factors, as well as other chronic diseases. So this is the campaign for the 2019 World Health Organization World Hearing Day, which was just last month on March 3rd. And the aim of the campaign was to raise hearing loss and deafness and promote ear care and hearing loss prevention worldwide. And this year's focus was on Check Your Hearing with the goal of promoting early identification and prevention of hearing loss. And I think that this really highlights the impact that hearing loss can have on daily functioning. So in children, when hearing loss is present, it can present with many of the symptoms of attention deficit disorders, learning impairments, or cognitive delay. And these include having difficulty attending to spoken or other auditory information, frequently having to request repetition, having isolation from their peers, having difficulty with reading, as well as spoken and written language. And the chart shown on the right is taken from the Academy of Audiology 2011 guidelines on pediatric hearing screens. And essentially what it's showing is the percentage of parents who report problems in these indicated domains, and I'll read them because I think that's probably pretty small. Social skills, grades in school and development of language, emotional health, relationships with peers, self-esteem, and relationships with family. And as you can see, there's an impact on each of these areas reported by over 1/3 of parents. And then lastly, children with hearing loss have lower educational achievements, being more likely to repeat grades, more likely to drop out of school, and less likely to attain a university-level education, with one study suggesting that children with hearing loss are about 1/3 less likely to attend college. And the impact on social functioning and achievement continues into adulthood. So people with hearing loss have lower labor participation rates, with some estimating twice as much unemployment and twice as much work-related stress as normal hearing individuals. And they've also been shown in one study to have half the median income. Loss of hearing can also lead to a significant sense of isolation, as many people do withdraw from social interaction, and this can include from friendships as well as with family relationships. People with hearing loss have higher rates of depression and of anxiety. And then in addition to psychological health, there's also an impact on cognitive functioning in general, with research supporting a relationship between age-related hearing loss, as well as and both cognitive impairment and dementia. And hearing loss generally precedes dementia by between 5 and 10 years and may actually be a pathway for intervention to improve functioning. One recent study reviewing health insurance claims over a 17-year period highlighted the overall impact of hearing loss on health, noting that patients with hearing loss were found to have significant differences in health outcomes and cost in the 10 years following their diagnosis. These included almost 50% higher total healthcare costs, 50% more hospitalizations, and higher rates of readmissions and emergency department visits. And I think you can get a sense that if someone's missing every other word that you're saying to them and trying to communicate about their health condition, that could certainly be an explanation for why this is the case. So I'm going to run through a quick review of auditory physiology. I apologize, I'll try to move through it somewhat quickly so this doesn't feel too much like a medical school lecture. But generally, as the first portion of this diagram indicates, initially sound waves are funneled into our ear canal, with the difference in the sound timing and amplitude between our two ears assisting in the identification of the directionality of a sound source. The vibrations of the tympanic membrane that are at the medial end of the canal are transmitted through the malleus, incus, and stapes bones, with a combination of the difference in area between the tympanic membrane and the stapes footplate, combining with the lever action of the ossicles, creating a 20 decibel gain in amplitude as the sound traverses the middle ear. And then these vibrations at the stapes are transmitted through the oval window into the cochlea. And the cochlea consists of 3 fluid-filled chambers traveling along the length of the spiral, which are the scala vestibuli, scala tympani, and scala media between them. The scala vestibuli and scala tympani contain perilymph fluid, and scala media contains endolymph, and this difference creates an electrochemical gradient. And the organ of Corti, which is the sensorineural organ, resides in the scala media, and it contains hair cells on which are stereocilia that are deflected by the shear forces that are created by the pressure waves traveling through this fluid. So deflection of the stereocilia is what leads to transmission of action potentials down spiral ganglion cells, which are the afferent nerve fibers of the auditory pathway. And the organ of Corti and the basilar membrane that it rests on are called the cochlear partition. And as the wave travels through the scala vestibuli, around the apex and back down the scala tympani, it causes the cochlear partition to vibrate as well. And this is what leads to those shearing forces that initiate that signal. And it's structured such that the high frequencies resonate best at the base of the cochlear partition, and high frequencies best at the base, and low frequencies best at the apex. And that's therefore tonotopically tuned to different frequencies along the full length of the cochlea. And that tonotopic organization is preserved along the entirety of the auditory pathway all the way to the auditory cortex. And sound information also gets incorporated with other brain areas such as those involved in language and emotion. Okay, done with that. So hearing aids are devices that can augment sound signals and are an effective option to treat many patients with hearing loss. So because of the notable impacts of hearing loss on health and quality of life that we've just briefly reviewed, it's incumbent on us to identify hearing loss early in order to help treat it early. But in spite of the fact that hearing loss is such a prevalent and disabling condition, only 1 in 3 adults who would benefit from having hearing aids actually do have them. So what does it mean to be eligible? Basically, if someone has a sensorineural or other non-treatable hearing loss that's impacting their ability to communicate effectively, they're a candidate for a hearing aid. Unfortunately, there are many patients who try hearing aids, find they don't quite meet their expectations, and then either return them or leave them sitting at home unused. And this is really a reflection of the fact that they're not simply one-size-fits-all amplification devices. They do require working with an audiologist to actually tune the aid to the patient's hearing using a combination of the patient's audiogram, objective measures of the devices as they sit in the ear, as well as subjective reporting of the sound quality. So it's therefore worthwhile encouraging your patients who haven't found them useful to actually meet again with an audiologist and make sure that their devices are being optimized, as well as making sure that they're the right kind of hearing aid for them. Because hearing aid devices can vary, so in general they consist of a microphone to pick up sound, an amplifier to augment the sound intensity, a receiver or speaker to project sound into the ear, and a battery to actually run the device. And there are an assortment of fits for hearing aids with devices that fit over the back of the ear, ones that rest at the external auditory meatus, and ones that sit entirely in the canal. But there are also slightly different devices that may be more appropriate for selected types of hearing loss. And these include devices that implant into the bone in order to transmit vibrations to the cochlea directly, bypassing that conductive component that we talked about of the external and middle ear. These are called bone-anchored hearing aids, or BAHAs, as well as devices that route sound from the poorly functioning ear into the better hearing ear. And these are called cross aids, or contralateral routing of sound. So hearing aids in general have incorporated a number of useful features these days that many people might not know about. So they utilize software that enables them to take into account background noise, music, the direction of the primary signal, and even what the other device is hearing. And they can control for sounds such as wind or other complex noises. Hearing aid users can have a loved one wear a microphone that connects wirelessly to their hearing aids. They can connect to the user's cell phone signal to directly stream cell phone calls, as well as to other devices such as televisions or smart speakers. And lastly, they can connect to loop systems in the community, such as in movie theaters or religious institutions that enable public access to their audio signals. So referring someone for evaluation of their hearing loss will result in a visit with audiology and a subsequent visit with an otolaryngologist to review the results and perform a history and examination to determine the possible etiologies and review treatment options. So a visit with audiology assesses several different aspects of hearing, and I'm just going to run through them briefly because you may see these results. So an assessment of pure tone thresholds will be mapped onto an audiogram such as the one that's indicated here. On the x-axis are sound frequencies within the majority of the range of human hearing, and the y-axis indicates decibels, or the sound level. The picture shown indicates what we call the speech banana, or the frequency and intensity of the sounds of human speech, as well as examples of other common sounds. Pure tone audiometry tests air conduction, or the sound as it travels through our normal auditory structures, as well as bone conduction, which vibrates the skull and transmit that sound energy directly into the cochlear fluid. So air conduction therefore measures essentially our functional hearing, and bone conduction measures the sensory neural capability. Speech testing is the next one. So it consists of evaluation of the sound level and accuracy of speech perception as opposed to the pure tones that I just reviewed. So often the speech reception threshold is identified, and this assesses the lowest sound level at which the listener can repeat a spoken word. Additionally, the audiologists evaluate the word recognition score, which plays words to the patient at a loud enough volume, and this is usually set at about 50 decibels above the SRT, and has the patient repeat them back. And though it may not be intuitive at first, making sound louder does not always improve speech understanding. The information that's conveyed by our auditory system is complex, and sensory neural loss leads to loss of information in addition to this loss of sensitivity. So the accuracy of this test is actually a very helpful assessment, as it can be a predictor of success with hearing aids. And poor word recognition scores may suggest that hearing aids are unlikely to improve speech understanding and are actually one of the criteria that's used to assess for cochlear implant candidacy. Tympanometry, and this is used to assess the mobility of the tympanic membrane, indicating the pressure within the middle ear, the integrity of the tympanic membrane, ossicular continuity, and eustachian tube functioning. Commonly, it can be used to determine the presence of fluid in the middle ear, which is poorly compressible in contrast to an air-filled middle ear space. And this would show a flat tympanogram. But a flat tympanogram can actually also be seen if there's a perforated tympanic membrane. Negative middle ear pressure may indicate that there's eustachian tube dysfunction, and then ossicular fixation and ossicular discontinuity can also be suggested by abnormal movement of the tympanic membrane. Acoustic reflexes. These test the integrity of pathways that involve cochlear nerve functioning, manifesting with contraction of the bilateral stapedius muscles. And typically, these are muscles that contract at between 70 and 100 decibels and alter the tympanic membrane compliance. And abnormal reflexes can indicate middle ear pathology that prevents the tympanic membrane from responding normally, but it can also assess for retrocochlear abnormalities, such as tumors of the vestibular cochlear nerves that interrupt the reflex pathway. There are also additional tests that are not standardly done but can be considered, including speech and noise testing, which assess higher levels of auditory processing, as well as extended high-frequency pure tone thresholds, which assess higher pitch hearing levels and may be more sensitive for early hearing decline. So there are several times when someone in emergency medicine, primary care, or another specialty might become concerned about an ear condition that's affecting someone's hearing. And so I'm going to run through a few rather quickly just to give you a couple pearls and then focus the rest of the talk on one particular hearing-related emergency. So infections of the ear include otitis media, which necessitate oral antibiotics if the tympanic membrane is intact, and otitis externa, which can generally be treated with topical medications. As a quick side note, mastoiditis, or inflammation within the mastoid cavity, will often be seen in imaging in the setting of a middle ear effusion because this middle ear space communicates with mastoid air cells. And this is in contrast to clinical mastoiditis, which is what most people mean when they use the term mastoiditis. And that basically presents with erythema, tenderness, and edema of the skin over the mastoid, which can cause protrusion of the auricle. And that is a signal of a more complicated suppurative infection that could require a surgical intervention. Okay, injury. So injury to the ear can occur from penetrating objects like Q-tips, pressure changes such as diving, or acoustic injury from blasts, or even actually just an open-handed slap to the ear. And damage can include hearing loss as well as vertigo. Tympanic membrane perforations can be treated with topical antibiotic drops to clear blood, but these patients should be referred to ENT. They are often managed conservatively, just with rest and monitoring, but surgical management may be required in some scenarios, so it's important to have that evaluated. Vertigo symptoms typically resolve over several days, but hearing loss outcomes are variable. Foreign bodies in the ear canal can be challenging. So objects like Q-tip heads, hearing aid parts, or small toys can easily get stuck in the ear. And repeated attempts at removal can cause trauma to the canal. So that can increase pain, swelling, and risk of infection. So if you're at all concerned about your ability to get something out of an ear canal, it's probably best to just refer to ENT because with our microscopes and instrumentation, they're typically fairly easily managed. If it's something that's alive, like a bug, you can take care of it by drowning it, and you can do this with mineral oil or with earwax drops, but I would avoid using lidocaine unless you're sure the tympanic membrane is intact because that's an ototoxic medication. And then the bug itself should be later removed with the assistance of a microscope. Okay, and then lastly, I want to focus the rest of this talk on management of sudden hearing loss. And the main point is, don't ignore or minimize symptoms, evaluate them. And the reason that I call this a true emergency is that this is one condition that the physician or other provider really needs to be attentive to keeping on their differential. So other conditions will often cause patients to return to get care if they're left untreated. So infections will progress and cause pain or drainage or systemic symptoms. And injuries often worry people enough that that they press for care. But I've had patients who come to me after being treated for 6 weeks with nasal steroids because they complained of a plugged or blocked ear, and their audiogram actually shows that they have a pretty significant unilateral hearing loss. So sudden hearing loss can be subtle, and it's most effectively treated early in its course. So it's important to take seriously any report of a hearing loss or a related complaint and fully consider the possible causes of them. So there are clinical practice guidelines that have been produced by our Otolaryngology Society, and the most recent version was produced in 2012. Another version is actually due out this year, and I was really hoping to have it released to be able to share the findings with you, but it won't be due out till later this summer. At the end of the talk, I'll be providing a link to our society guidelines so you can look it up yourself. I did also speak with some of my otology mentors in the field who are pretty well-connected, and as far as they understand, there aren't going to be any major changes from this, but there might be some subtle differences. So, sudden sensorineural hearing loss is defined as a loss of at least 30 decibels affecting at least 3 contiguous frequencies over a 72-hour period. And this definition is a useful research criterion, but practically we don't treat these according to this rigid of a definition. Really, a noticeable hearing loss that's reported by a patient with an audiogram that shows asymmetry or a change from a prior audiogram, if they do have one, would warrant a discussion about treatment. And often the loss is more rapid than this, occurring within less than 12 hours. The prevalence has been determined to be between 5 and 20 cases per 100,000 people who meet these strict criteria. But since I've been here just for the past 6 months, I've already seen a handful of cases. So there is some thought that these numbers are an underestimate, as well as the fact that we brought in our treatment from this very narrow definition. So the goals of initial management are to rule out worrisome etiologies such as a stroke, a vestibular schwannoma, or malignancy, and then to treat with the strategies that we currently have to maximize the chances of improvement. 1 to 2/3 of patients will have improvement spontaneously, but improvement is not the same thing as resolution back to someone's baseline, and there is actually some thought that this number might be an overestimate of the true results. So while workup can reveal a clear reason for the hearing loss in some cases, for the vast majority, the etiology is unknown. There are a few theories. One is that there is inflammation secondary to a viral infection, perhaps a direct viral injury to either the cochlea or the cochlear nerve, or reactivation of latent virus in the spiral ganglion cells. Another explanation is ischemic damage via embolism, vasospasm, or hemorrhage. Antiviral medications and various therapies to induce anticoagulation, counter vasoconstriction, or modulate injury secondary to free radicals have all been studied, but none of these have reliably been found to improve recovery over placebo, so they're generally not recommended. There are, however, a few evidence-based options for management, which I will get to shortly. So when patients do develop sudden hearing loss, the presentation can be variable. It may entail sudden severe vertigo, loud tinnitus, and a drastic reduction in their hearing, or it can manifest with the sensation of a plugged or blocked ear alone. The main symptom patients complain of is ear fullness or a blocked ear, which is obviously very nonspecific. And usually there is associated tinnitus, but vertigo is less reliable, occurring in fewer than half of cases. So whatever the severity initially, it's important to recognize that there are non-otologic symptoms that can often accompany this episode, anxiety and depression. So the loss of sound in one ear can be frightening and literally disorienting for people, and it has a significant impact on their quality of life, as we've already reviewed. So when new onset tinnitus and vertigo are also present, the burden on a patient can be even more dramatic. And it's important to recognize these features and provide appropriate support and counseling to them. Most recovery occurs within the first 2 weeks, with recovery progressively less likely beyond that time period, and that's why it's important to identify this early. Prognosis appears to be affected by age, the presence of vertigo, the severity of the loss, and the shape of the audiogram. Children and people over age 40 are less likely to recover. Those with vertigo and those with a more severe loss have a poor prognosis, and downsloping and flat losses on the audiogram have found to be less likely to recover. So because of the possibility of this condition, it's important to fully evaluate a patient noting unilateral hearing loss, new tinnitus, or a sensation of blockage in the ear. Important questions to ask include a history of a prior hearing loss, any history of trauma, the presence of pain or drainage, neurologic symptoms which might prompt a more acute workup, or systemic symptoms. And a physical exam is also necessary. So conductive loss might be supported by findings of cerumen, fluid behind the tympanic membrane, a foreign body, a perforation, or edema of the canal. But importantly, a normal exam should not be taken to mean that there's nothing wrong, because a sensory neural loss won't manifest typically with any visible exam findings. So in order to help differentiate between conductive and sensory neural etiologies, the tuning fork exam is recommended, and this entails 2 tests. So the first is the Weber test, where the tuning fork is placed in the midline against bone. And this is typically the forehead, sometimes through a gauze onto the front teeth. And the patient is asked if they hear it louder on one side. So if they say in the middle or I can't tell, that's normal. And if it lateralizes, that indicates that there is a hearing loss. A Weber test will lateralize away from the affected ear in a sensory neural loss because one sensory neural component is weaker than the other side. In a conductive loss, sound will lateralize toward the side of the loss on Weber testing, because of competing noise appreciated through air conduction in the healthy ear, as well as due to reduced dissipation of sound energy in the blocked ear. And then the Rene test can also help to determine if the hearing loss is conductive or sensory neural. And for this one, the tuning fork is placed behind the ear onto the mastoid bone, and some people hold it there just momentarily, and others wait until the patient can no longer hear it, but then it's moved in front of the ear. If the sound is heard better in front of the ear, that's normal conduction. But a sound heard better through the mastoid indicates that they have a conductive loss. And this is because the vibrations of the tuning fork are being conducted directly through the mastoid to the cochlea, whereas sounds that are in front of the ear are impeded by their conductive problem and sound quieter. So you can take advantage of these principles by asking the patient to perform their own hearing test if you don't have a tuning fork. If you press on your tragus and plug your ear right now and then hum or talk, you'll find that sound lateralizes to that side. And I can pause for a moment while you all try this if you'd like. Yeah. Okay. So you can ask your patient to hum and determine whether and to which direction sound lateralizes. And the use of this test has actually been studied at NYU and was found to be comparable to the Weber test. So they evaluated this by asking subjects to first hum at a subjective high pitch for a few seconds, and they were then asked if the sound was more pronounced on the left or the right, or if it was perceived equally. And they were then asked to repeat the humming at a low pitch. And both pitches were then repeated to confirm and ensure reliability. So for the hum test performed with high-pitched humming, the sensitivity and specificity for conductive hearing loss were 89.7% and 100% respectively. For the hum test performed with low-pitched humming, they were 93.1% and 100%. For the Weber test, they were 96.6% and 100%. So there was no statistical difference in sensitivity between the high-pitched hum test and the Weber test, or between the low-pitched hum test and the Weber test. And the paper cautions that this is not really a reliable test for complex ear pathology, but really is meant to be useful either if you don't have a tuning fork exam in situations like telemedicine, or if you need to help narrow a differential as to the underlying cause of a hearing loss. So, despite our lack of understanding about the etiology of sudden sensory neural hearing loss, there are recommendations for treatment. Oral steroids have been the mainstay of therapy for a number of years. However, the quality of the evidence behind them is actually not fantastic, but generally our guidelines do suggest that they are an option for initial therapy, and practically most people do suggest them given the relatively positive risk-benefit profile. Our guidelines report a 10 to 14-day course of high-dose steroids as a common regimen, but where I trained, it was actually not uncommon to treat for 2 or even in some cases up to 3 weeks at the maximum dose before tapering. If you do have a high suspicion for a sensory neural loss, and you have this documented by an audiogram, but they aren't able to be seen by ENT for a few days, it's a good idea to consider at least offering a high-dose oral steroid to the patient after a thorough discussion with them of the risks and benefits of steroids. So intratympanic steroids have also been well studied, and the current guidelines recommend offering them to patients who have not responded after initial management. They can also be considered as an alternative to oral steroids when oral courses are contraindicated or felt to have excessive side effects. And there may additionally be some benefit to the combination of oral and IT injections simultaneously. And these injections are performed in our offices. They typically involve using a drop of phenol as a topical anesthetic onto the tympanic membrane, the insertion of a 25-gauge spinal needle to create a ventilation hole, and then injection of the medication through an additional site where it fills the middle ear space and is thought to diffuse across the round window membrane. There are few systemic side effects with rare hyperglycemia in diabetic patients, and reported safety even in patients with cataracts and glaucoma. The most notable risk of this is a persistent perforation of the tympanic membrane, but this is infrequent. And despite overall evidence showing some value as a treatment, the studies are actually varied in the particular drug administered, the overall dosage, and the timing of this. So it makes it difficult to compare studies and extract one optimal treatment course. Typically, injections are performed on a weekly or twice-weekly basis for a total of 3 or 4 injections. And in our office, we use dexamethasone, 10 milligrams per mil, and I typically inject between half a cc and a cc on a weekly basis for 3 weeks, with consideration of a 4th dose if there is some improvement. Lastly, hyperbaric oxygen is considered an option within 3 months of onset. And this involves treating patients with 100% oxygen at greater than 1 atmosphere of pressure in order to increase the partial pressure of oxygen that's delivered to the cochlea. And due to the potential role of ischemic damage in the pathophysiology, it's thought to have the potential to counter or modulate the downstream effects, as well as possibly augment the immune responses to the damage that's present in general. And there are not many large prospective studies, but a 2007 Cochrane review did find some benefit to this. Generally, outcomes were better in younger patients with a cutoff defined as between 50 and 60 years of age. If the treatment was performed early, which was generally deemed to be within the first 3 months, but it was thought to be more effective if it occurred in the first several weeks. And additionally, if the hearing loss was greater, which they defined as at least 60 decibels. And side effects from treatment can include damage to the ears, sinuses, or lungs from pressure changes, claustrophobia, visual problems, and oxygen toxicity. There are not well-defined treatment protocols for this, but the reports do suggest maybe 5 to 10 sessions with 1 to 2 hours per session over a period of days to weeks. So commonly people ask after this diagnosis, when will my hearing get better? And the studies that have been done do not use a consistent criteria to define their recovery, but the guidelines propose a set of criteria which classifies improvement as follows here. So a complete recovery requires return to within 10 decibels of the unaffected ear, as well as recovery of word recognition scores to within 5 to 10% of the unaffected ear. Partial recovery depends on whether the loss led to hearing that was usable or not. And so if not, then any return to hearing that can be usable with the addition of a hearing aid should be considered a partial recovery. And then for hearing loss that was still serviceable, a 10 decibel improvement in pure tone average or an improvement in word recognition score of at least 10% should be considered a partial recovery. But improvement of less than 10 decibels in pure tone averages should be considered no recovery. So there were long-term outcomes that were obtained in over 150 patients in South Korea who were treated with therapy that included a hospitalization as well as treatment with a 10-day course of steroids. They were followed for over 6 months. And in this cohort, 78% actually recovered some hearing. And of those who recovered, just over half reached their final hearing outcome within the first 10 days of their treatment. And though 45% did take longer than this, 90% of those who recovered hearing had reached their final hearing status by 1 month, 98% by 3 months, and only 2 people had any improvement beyond that point. So the current recommendation is to reassess hearing with a formal audiogram within around 6 months after the onset of hearing loss to determine final hearing results. And I think this lingering unknown, so will my hearing recover? What will life be like for me with this new hearing loss if there is some residual loss, can be very uncomfortable for patients. And so fortunately, there are resources for people with hearing loss, and it's important to mention these to your patients, resources of some kind. The Hearing Loss Association of America and the International Hearing Society are both large organizations for the hearing impaired that might be helpful for some of your patients. Hopefully today's talk has provided you with some education to improve your ability to help serve your patients with hearing loss in general. And then more information about sudden hearing loss and a couple of the other topics I briefly mentioned, including otitis media and otitis externa, can be found at the Academy of Otolaryngology Head and Neck Surgery website in the section on clinical practice guidelines. So in summary, hearing loss has implications for the health and daily functioning of both children and adults. Current technologies have enabled hearing aids to provide hearing benefits beyond simple amplification. Hearing loss should be identified and patients referred for evaluation. It's important to have a low threshold for suspicion for sudden hearing loss, as it can have subtle presentations but lead to significant long-term consequences. The hum test can be used as a more thorough assessment of hearing than simply observation of their communication or finger rub next to the ear. And our Academy has produced a number of helpful guidelines for conditions of the ear, nose, and throat that are all available on our Academy website. And so lastly, I just want to take a moment to acknowledge my colleagues, Drs. Zekui, Homich, and Huang, who I've been very fortunate to have the opportunity to join here in Santa Rosa. And I'd also like to thank our fantastic audiologists, John, Kristen, and Jamie, and our wonderful staff for all that they do to care for our patients. So thank you all for your attention, and I'm happy to take any questions either now or after the conference.
Hi, thanks. So with the first case, you sort of alluded to the patient that has had this plugged ear.
Yeah.
And, they end up getting treated for, eustachian tube dysfunction forever. At what point do we need to send them for an audiogram? I mean, when do we need to be thinking about this if you suspect sudden sensory neural hearing loss?
Right. So generally, I think the time course is really helpful for that. Like eustachian tube dysfunction or something like that would be treated. Often people don't present in the first couple days saying, I've had an acute drop in my hearing, and so that's one of the things. If people say there's something that suddenly changed recently, I think that should be a red flag. And then additionally, the hum test to basically suggest, is there some, could this be a conductive etiology? Sorry. Could this be a conductive etiology? Could this, other, maybe from an effusion if they have other symptoms of a URI or something like that, or any other symptoms to suggest eustachian tube dysfunction. So I think the timing and physical examination should be helpful to help triage that. But you can also, call if you have any questions. I've also fielded questions from the ED, from primary care doctors about, hey, I'm concerned about this. Should I do something? And we talk through it a little bit. And I've counseled people about the humming option to just try to give a sense of what might be going on. Yeah.
I have a question about treatment of chronic hearing loss. I understand the first line, and I understand what's possible now that wasn't possible before.
Yes.
I have a lot of patients who are interested in what's the second line. They say, should I even go to the audiologist if I already know I can't afford a $3,000 to $6,000 hearing aid?
Yeah.
Or should I buy something that I saw in Parade magazine that's $50 and it's just or maybe Radio Shack, it's a pure amplifier. Will it do harm for them to just carry around a little microphone in their pocket and point it toward people? Is that causing new damage, or is that the second line therapy?
Yeah. And I don't know of any damage that would be caused by that. I think certainly that sort of falls into the category of the one size fits all, and it may make things louder for them, but not necessarily help them understand speech better, and that's tough. I think that one of the problems with hearing loss is that it sort of narrows the range of hearing to the point where sometimes really loud sound can be actually uncomfortable, even if they do need it louder. And I think sometimes working with our audiologists to have even some of maybe the less high-end true hearing aids, that might be finding something that is still maybe closer to affordable, might be one option. I think meeting with the audiologist, at least, I don't know the costs, honestly, of just meeting with the audiologist to have a hearing aid evaluation, but I think that they can give some counseling that would be helpful. And yeah, I hope that's helpful. Yes.
For someone with otitis media with a perforation,
Yeah.
otitis media with a perforation, either a grown-up or a kid, is it okay to give them a few weeks and see if it heals back up, or is it always an instant referral?
Yeah, so that's a great question. Most tympanic membrane perforations that occur in the setting of an infection do heal on their own. So it's totally fine for that to just treat with appropriate antibiotics and monitor. Is that your question about referring for the perforation itself? Yeah. So typically those do resolve, similar to our perforations that we induce for our injections, and they typically do. And if it doesn't seem to resolve, weeks down the line, then they can certainly be evaluated with us. Okay. Yeah. Thank you.